So today we'll be talking about the rheumatic heart disease. Rheumatic heart disease. So it is mainly concerned with large joint involvement. Large joint involvement. Now we often get confused with the rheumatoid heart disease. It's mainly involved small joints. So large joint means mainly elbow, knee, ankle. Small joint means phalangeal joints, interphalangeal joints, etc. Now, what is rheumatic fever? Rheumatic fever. So, what is the organism involved? Organism involved. The group A, beta hemolytic streptococcus. What happens actually? Group A, beta hemolytic streptococcus. So it has M antigens, and antibody forms against it. These antigens. Now, what actually happens? We have all read in microbiology the term cross reaction. So, antibody cross reacts with the connective tissue. Cross reaction. Antibody cross reacts with connective tissue. Antibody cross reacts with connective tissue. Now, actually, in the connective tissue, the product is in acetyl glucosamine. To which the cross reaction occurs by the antibody cross reaction. Now, a kind of type 2 hypersensitivity reaction occurs, and this cross reaction is also known as molecular mimicry. Molecular mimicry. Now, by this cross reaction, Ascoff nodules forms. Formation of Ascoff nodules, and these nodules are pathognomic feature of rheumatic fever. So these are the pathognomic feature of rheumatic fever. Now, these nodules also known as anti-SAW cells. Also known as capillary cells, caterpillar cells. Caterpillar cells. Now, under the modified Jones criteria, updated in 2015, we divide into major and minor criteria. So starting with the major criteria. No, major criteria. So, number 1, pancreatitis is inflammation or infection of 3 layers: pericarditis, myocarditis, and endocarditis. Now, what are the features? 5 to 15 years, recurrent sore throat, chest pain at rest. So the pancreatitis, under pancreatitis there is pericarditis, myocarditis, and endocarditis. So what is the feature of the pericarditis? So it usually occurs within 5 to 15 years of age with recurrent sore throat, chest pain even at rest with ST elevation. Management: steroids. Coming to myocarditis, which is manifested by acute pulmonary edema, acute congestive heart failure, MRNTR functional, and pansystolic murmur. Now the management part, we have a mnemonic that LMNOP. So what is L here? L stands for LASIK. LASIK. M for morphine. It's a life-saving drug. N for nitroglycerin. O for oxygen, and P for position. What is position here? Head high position. Head high position means sitting positions with 45-degree angle. Life-saving drug. Now, endocarditis. So we categorize the type of endocarditis under 3 subtypes: valve involved, valvular relation, and surface. Valve involved, valvular relation, and surface. Now, valve involved. Most common valve involved is mitral valve. And most common not involved, that is the valve not involved, is pulmonary valve. But not involved, pulmonary valve. Under valvular relations, 5 years of child with rheumatoid heart disease with mitral regurgitation. So child having 5 years with MR, with rheumatoid heart disease. When the child grows to 18 years with rheumatoid heart disease, it can have mitral stenosis. Even sometimes it can have mitral stenosis with MR, that is mitral regurgitation. Acute carditis happens in MR. Acute carditis. Acute or active? Carditis occurs in MR, that is mitral regurgitation. And overall is mitral stenosis. Generally, mitral stenosis is more common than mitral regurgitation, but in case of child, MR is more common than MS, since it takes time for the valves to get stenosed. Now, the surface. There is a commissural end involvement. Why it is in involvement? Because if we draw the valve leaflets, suppose there is the left ventricle and these are the mitral valve. Now we can find ascope nodules in the upper surface area and lower surface area of the valve leaflets, but the most common area where we can get the nodules are the end valve commissural points. Here the commissural involvement occurs. Commissural involvements here in these zones at the end points of the valve. So it is also the tip of the valves. So characteristic murmur is found here. Characteristic murmur can be found here, known as Carey-Coombs murmur or flow murmur. Carey-Coombs murmur or flow murmur. Carey-Coombs murmur or flow murmur. Now, what is the characteristic feature? Why the flow murmur is heard? Now, actually, generally what happens in case of mitral regurgitation, generally blood flows from the left ventricle to the left aorta. But since when aorta is filling from the both sides by regurgitation as well as in normally, it happens the pressure of the aorta increases and the blood flow starts from aorta, left aorta to the left ventricle. That is, in due course of time, extra blood goes to the left ventricle from the left aorta, left ventricle. Now, due to this, the characteristic murmur is formed, which is known as Carey-Coombs murmur or flow murmur, due to flow of the blood from the left atria to the left ventricle. Now, coming to the management part, we can give here steroid like the pericarditis. Management. For severe stenosis, for severe MS, we know for severe MS, so the area should be valve area should be less than 1.5 centimeter square, and we can manage it through percutaneous mitral balloon valvotomy. Percutaneous mitral balloon valvotomy. And remind that, and we should not apply steroid here. Steroid shouldn't be used. And for MR, valvuloplasty is done. So, coming to the second part, that is the arthritis. Number 2. After pancreatitis, we're coming to the arthritis part. So, what are the earliest manifestations? It is the history of sore throat within 2 weeks. History of sore throat within 2 weeks. Ankle swelling, knee swelling, and elbow swelling. And this is known as migratory polyarthritis. Migratory polyarthritis. Here what happens, suppose ankle is swelling. So after ankle swelling, within 2 days it subsides. Again within 2 days, after 2 days, knee swelling occurs. Again it subsides. Then elbow may swell. So the swelling migrates after intermediate subsiding of the swelling It is known as migratory polyarthritis. Now, we will focus on the endemicity of this. So, in low endemic states like USA, low endemic states like USA, we can see this migratory polyarthritis. But for high endemic states like India, if single joint is involved, it is called monoarthritis, and which is sufficient for diagnosis of arthritis. That means we wouldn't have to wait for all the three consequences, all the three other swellings to confirm the diagnosis as arthritis. We can easily diagnose we just seeing or investigating any one of the swelling. Now the management part. How can we manage the arthritis? We have two regimen. One is aspirin plus varicella zoster virus. Another aspirin plus influenza B virus. Now, these two viruses give rise to Ray's syndrome. Ray's syndrome, and it's a type of mitochondrial encephalopathy. It's a type of mitochondrial encephalopathy. Mitochondrial encephalopathy. Now, the third point, that is a new name, Sydenham chorea. So it's a chorea. So it's basically a late manifestation. What is it? It's a late neurological feature. What happens here? Damage to caudate nucleus. Basically, the antibodies that are formed against the M protein of the group A beta hemolytic streptococcus enters the brain and attacks the caudate nucleus. Now, purposeless or semi-purposeful involuntary distal movements. Purposeless involuntary distal movements. Sing. Poor handwriting. Which decreases school grades. Now, on examination, we can see or appreciate the darting tongue. What is darting tongue? Darting tongue is that inability to keep a tongue in stable position. That means we can say a child that please take out your tongue, and then he can't keep his tongue in a fixed position. So it will tremble. Now, milkmaid grip. He or she will have shaky hands. Number 3, hung up reflexes. If he or she has hypothyroidism, he may result or end up in hung of ankle jerk in mesoderma. Dysarthria or unclear speech is also noticeable. Unclear speech, known as dysarthria. Now, for the treatment modalities, basically it's self-limiting condition. For the less than 6 months to 12 months. But we can also give valproate. Also give haloperidol, phenobarbital. If this fails, we can give steroids. Even if steroid not works, we can give intravenous immunoglobulins. Now we can give intravenous immunoglobulins. Now, what is athetosis? Athetosis is slow distal movement. What is athetosis? It's slow, breathing distal involuntary movement. Involuntary movement. And what is the lesson? The lesson is in globus pallidus. Now, coming to the fourth part. Subcutaneous nodules or rheumatic nodules. Subcutaneous or rheumatic nodules. What are its distributions? Generally in extensors. Sites: olecranon, occiput, and spinous process of the vertebra. Spinous process of vertebra, occiput, olecranon process. Now, coming to the minor criteria. What are the minor criteria? Fever, arthralgia. What are the lab features? ESR is increased. Again, with low endemic USA and high endemic India. So in USA, it's greater than 60 millimeter fall per first hour. Fall in first hour. But in India, it's greater than 30 millimeter fall in first hour. To be a criteria of the minor criteria of the rheumatic fever. Now we can see SA node electrical impulse pass from SA node to AV node, and here the Ascoff nodules. As a result, prolonged PR interval. PR interval occurs. presented positive, and which is also known as first degree heart block. So this is known as the first degree heart block. These are the ASCOP nodules. Now, what is the diagnostic algorithm? Diagnostic algorithm to quality rheumatic fever. Number 1, it can be 2 major criteria plus evidence of preceding group A streptococcal infection. Group A streptococcal infection. Number 2, what is the other algorithm? Minimum 1 major plus 2 minor criteria of preceding group A streptococcus infection. Coming to the management part. Aspirin is given for arthritis. 2, steroids for pericarditis. 3, valproate or haloperidol for severe chorea. Remember, chorea appears last. Number 4, benzathine penicillin injection IM benzathine penicillin every 3 weeks with AST. What is AST? Antibiotic sensitivity testing. Why it's so important? If patient asks, why should I give injections? Why? To prevent future sore throat. And future sore throat. If the mother asks how long? How long? The answer would be rheumatic heart disease with mitral regurgitation is a lifelong phenomena and lifelong basis is ideal to keep ourselves medico-legally safe, but not practically. I am providing with a chart. The chart is rheumatic heart disease. Best answer, practical answer. This is the best answer. This is the practical answer. Rheumatic heart disease with valvular lesion. Rheumatic heart disease without valve lesion. Rheumatic fever. So, ideally, or the best time duration for the continuation of the IM injection of benzathine penicillin is 40 years. Practically 10 years. Rheumatic heart disease without valve lesion, ideally 1 year, practically 10 years. Only rheumatic fever ideally 21 years and practically 10 years. Now, if guardian says my child is allergic to penicillin, then the next drug should be azithromycin, followed by sulfadiazine. And for both these two, the time interval, ideal and practical time interval will be same as of benzethine penicillin. Now, one more fact I would like to make you know that chorea and arthritis can't coexist together simultaneously. They can be sequential. That means generally chorea appears late and arthritis appears early. So chorea can follow arthritis but never can coexist. Thank you.